There are different types of operating theater existing. I don't know whether you were working, have you been working or you're just studying? I don't know what is your practice, because some students, start their studies after some times of work. But let's say I have to assume that you don't know anything about the structure. So there can be within a hospital several small operating theater or one central, or theoretically it could be two central. It depends how big is the hospital, but generally several small or one central. Small units usually are located in departments. So there's a department of ophthalmology, and they have their own operating theaters. Usually it's one or two operating theaters, and sometimes it is in separate buildings. It makes organization of hospital work more difficult if the hospital is located in separate buildings. Our hospital for many years was a hospital of a few buildings. Now we are a big one, which is almost, I think that right now everything is united, so we don't have to go outside to go to another department. When there is in case of small operating units, there are advantages and disadvantages. The planning of operating schedule is relatively easy. There is less organizational problems in routine situation. However, when complications occur, it's more difficult to get help if you are somewhere far from general building of the hospital. Those who are working in a small units, small operating rooms, they have some kind of positive identification. This is my own operating theater, my small ward. This is I feel at home almost in this operating theater. But when there is an absence of one nurse, it might be critical to replace the nurse, and it may cause several disturbances of daily routine. And inefficiency might be high because inefficiency in terms of the whole hospital. Because if there are no operating operations scheduled, or they finish earlier, the operating theater stays empty. There is no possibility to transfer the patients from another operating room, because the patients are in other operating theaters somewhere in other building. And those small operating theaters are too specialized to admit a patient. For instance, ophthalmology operating theater will have problems with operating somebody with ear pathology, because they have another equipment, the nurses who are at the operation, they are not used to devices necessary for ear operation, etc. So this is the disadvantage of small operating theater. If there is one central operating room in a hospital, there are also some problems. Planning of the schedule is extremely important. It must be done in advance and must be corrected every day. So for instance, the person who is responsible for such big operating theater, like we have in our hospital, wants all the surgeons or units to give a schedule general schedule in a week advance. Is it working? Sometimes it does, sometimes it doesn't. Generally, the precise operating schedule is corrected the day before. there is a variability of procedures performed in the operating theater. This is everything must rely on the schedule. There must be always a place, at least one operating theater waiting for urgent operation. It's possible to use maximally the operating theaters to have a maximum efficiency of using it, because if one operation ends earlier, the person who is responsible for the organization may transfer the patient who was supposed to be operated on the room number 2 to this room number 1. So it's possible it prevents from not being operated on that day. If the operating schedule ends too late, then the last person will not be operated. So these last persons from the operating list from room, let's say number 2, who was 9 or 8 scheduled, will be operated in room number 1 because room number 1 finished schedule earlier. So there can be this transfer can be performed, and it is performed. It's being performed every day. Everyone must follow the schedule, otherwise there will be a mess. The plans will disintegrate and people will be nervous, because if the plan is not followed, the schedule is not followed, the mistakes may occur. The biggest advantage of this one room is that everything is at one place. So if there is necessity to replace a person who is absent, it's easier to organize it. If help is needed, that's different type of help. It might be an anesthesiologist may need help, surgeon may need help, nurse may need help. So the other persons are nearby, so they can come and help. Good administration system and organization are crucial to keep the efficiency. Staff must be qualified, high qualified, must match clinical activity. The organization of the schedule of single room must be done in that way so the flow of the patient is not complicated. So it's impossible to schedule 5 long operations on the same theater, because you know that this 5 operation will not finish till the evening, and the operating theater is not working. The planned operation are not scheduled for 24 hours. So that's in our hospital, some operating theaters work till 3 p.m., some work till 7 p.m. So if you know that the room number 1 has scheduled till 3 p.m., it doesn't make sense to schedule patients 3 operations, each one lasting for 4 hours, because you know that it will never end. It will never finish before 3. So the organization must be it must be a logical one. It's good to have a preoperative or pre-anesthesia area when the patient can be anesthetized, and anesthetized patient will be transferred to the operating theater. It helps to get extra time, because you can anesthetize the patient before in the pre-anesthesia area, before the operating room is ready. So the previous operation is finishing, and already the next patient comes to the operating theater, is anesthetized in pre-anesthesia area, and when the operating room is ready, then the anesthetized patient is transferred from pre-anesthesia area to the operating room. But the problem is that it's not working in our hospital, I have to say, because if you want to anesthetize patient before the previous operation ends, you need to have more people, because one team is still in the anesthesia, working in the operating room, and the other team, and nurse and doctor, must be ready to anesthetize the next patient. So 2 teams are necessary. Eventually, there could be a team of a doctor and a nurse who is that they only working in anesthesia preparation. So this team may prepare every patient who comes to the operating theater, and after anesthesia induction, another anesthesiologist will continue the operation. It happens in some countries, but there's a problem with responsibility. If I start the anesthesia, then another anesthesiologist will come and continue the operation, the anesthesia, and something wrong happens. Who is responsible? The one who started or the one who continued? So so it's better if the team is working from, at least the doctor is working from the beginning till the end of anesthesia. And it's hard to then to use pre-anesthesia area if you don't have many anesthesiologists. And usually there is not too many anesthesiologists available in a hospital. In contrast, we are the specialization that is very high, in a very high level in a hospital, because we are not too many. And in this operating theater, there must be a fully resourced, dedicated emergency and trauma room. So for emergency, we should be prepared to open another operating theater. Sometimes there are two emergencies at the same time. Usually, these are not the emergencies that need to be operated immediately. So if there is an emergency going on and the second patient arrives or is qualified for emergency operation, then the first one must finish. Or if it's really emergency, then the schedule on another room, another operating theater is stopped, and the emergency patients is put into the schedule of the planned operation. So it's then there's a disruption of the schedule. So we should operating list for the one day should begin at agreed times. As I said, some rooms end at 3, some at 7 p.m. And we have to keep that, keep the times. If there are any changes done, everyone who is involved in this schedule must be informed. So anesthesiologist anesthesiologist team must be informed that the next operation will be something else, than another patient will come, for instance. And what is very important is that there must be also adequately staffed recovery unit within the operating theater, which is open during all periods of activity. So generally, if the operating theater is working 24 hours a day, then the recovery unit should work the same time, so 24 for 24. There is this recovery unit is a room within the operating theater. It's the room where patients wake up from anesthesia, or they stay for usually around 2 hours just to get better. If the patient is severely sick or in severe condition, or the operation was very, very long, the patient should go to high dependency post-operative unit, sometimes to intensive care unit. And this intensive care unit must be in every hospital. High dependency unit should be in every hospital. In Poland, it's not in every hospital. Instead, intensive care units are working as high dependency post-operative unit. In our hospital, here we have post-anesthesia unit within the operating theater, and we have post-operative high dependency unit close to the operating theater, as well as we have intensive care unit, which is also close to the operating theater. And because we have high dependency unit, we very seldom admit the patient to the ICU from operating theater. Severe trauma patients in severe condition that it's evident that he or she will need to be treated intensively for more than 24, 48 hours. Because in high dependency unit, patients shouldn't stay longer than 2 days. Usually they stay there 1 day. So if I anesthetize the patients in severe condition, and I know that this patient will not be extubated within next 10, 15, 20 hours, it doesn't make sense to transfer him postoperatively to the high dependency unit, because 2 days later, he or she will have to be transferred to ICU. So it's better just immediately in the postoperative period, take the patient to the ICU. Procedures, surgical anesthetic procedures become more and more complex. So the operating theater must be larger and also multi-purpose. There are in some specialization like neurosurgery, they require special equipment for operation, imaging, MRI. They have magnetic resonance device in the operating theater. And this MRI is not staying just open. It's hidden in the wall. So special construction must have been made, plus special anesthesia machines, special small devices which are used in this MRI operating theater must be compatible, must be cannot have metal in them, so they must be safe for MRI conditions. Surgeon use different microscopes, different X-rays, C X-ray. So there is a need for space in the operating theaters. The rooms cannot be small. We need to have some place around the patient, and we need to have the place in case of emergency. There must be more people in the operating theater, so the space is necessary. What is also very important is the systems of good communications and transport of the patient. The good communication between the operating theaters, between the person who is in charge of the operating theaters, and this person must be able to contact every operation theater when necessary. So intercoms, for instance, phones or intercoms. We have intercoms. And communication IT systems are obligatory. The staff must be skilled, qualified to work in the operating theater. And the schedule of the staff of the operating theater must be accepted by them. So there are some legal rules saying how long you can work, depending on the type of your contract that you have with the hospital. Either you are employee or self-employee, everything it differs, but there are some rules. So the schedule of the hours of work of the staff must be prepared in advance. And there must be enough people in the operating theater. The operating theater must be staffed enough to work effectively for a normal schedule and be ready to perform emergency operation. So in a situation when there is no emergency, the plan should not run full capacity of the operating theater. There must be always somebody, some staff, nurses, surgical nurses, anesthesia nurses, anesthesiologists, some surgeons. Just with surgeons it looks different, but because you never know which operation will be, which surgeon will be needed for the emergency operation. But generally, nurses, anesthesia and surgical nurses and anesthesiologists should be There should be a team waiting for urgent situations. So we cannot run 100 capacity because there must be someone always waiting just in case. It's crucial to perform, to work, to keep safety in the operating room. The mistakes, wrong patients operated on, or the wrong site being operated, it's a tragedy. So when the patient is admitted to the operating room, he or she must identify themselves. Yeah, proszę mnie. It is obligatory to ask about or to confirm this site of operation. We ask the patient, which site are you going to be operated? What are you going to be operated on? Which site? We ask the patient where he or she ate last meal, when was how many hours passed since the last drink. It's possible to drink clear fluids 2 hours before anesthesia, solid food 6 hours before anesthesia, and breast milk for children 4 hours before anesthesia. So we have to know if it's a scheduled operation, when the patient stopped eating and drinking. If it's an urgent, well, we do not. If it's an urgent, then this times are not important. I mean, they are important, but sometimes we cannot wait 6 hours since the last meal to anesthetize the patient. But the information we need this information. Before the anesthesia starts, we have to check the documentation if the patient signed consent for anesthesia, for surgery, and for eventual blood transfusion. There are operations which are connected with possibility of blood transfusion. So we need to find out whether the patient signed this or not. If it's an eye operation, of course, there is no need blood transfusion, so there is no need to look for signed consent. And also we have to check whether the patient agreed to be monitored in the operating theater. If there is no such agreement, then the cameras must be turned off. And this is there is a documentation of this, some of our some information that we ask the patient. This is the WHO perioperative checklist, and it must be filled before patients comes to operating theater. Two parts. Part C must be filled before anesthesia. Part D before skin incision, and Part E before the patient leaves OR. This is the example of surgical safety checklist. This is made by WHO, World Health Organization, and it can be modified. So this is the original, and the modified can look totally, maybe not totally. Usually there are some extra information, additional information added. And that's, we have in our hospital a modified version of this surgical safety list. So this is, it's in Polish, but that's how it looks like. So this is the A part, which is filled in by the nurse and the doctors in the surgical ward before the operation. B is performed by the A is by the doctor, B is filled by the nurse. If there is no, if there's a negative answer, it's stop, there's a marked stop, and if it's stop, operation cannot be performed, or we can just go further if there is an annotation. Like, for instance, has the patient identify an identity, well, I don't know the word right now, let's say card. This card, this identity sign is put normally on the patient's wrist. So, for instance, the patient doesn't have this identification sign. No, why? Because the patient has amputated hands, for instance. Yes, so I know this is a quite strange explanation, but if there is a good annotation, good explanation why there is a stop sign, we can go further. This is whether the patient agrees to the being monitored during intraoperatively or not. And then we have C, a part which we think and we sign before anesthesia, D before incision, E before patient leaves the OR after the operation. This is our Polish version. So after the patient is correctly identified, correct site of the operation, everything is before the operation is confirmed that everything is fine. Then there's an operation, and post-operatively patient goes to the recovery room, post-anesthesia unit. Theoretically, there should be separate for adults and for children in Poland. Right now, it's not obligatory, so we have if the children are operated, they also go to the same post-anesthesia care unit like adults. It must be within OR or close to the OR. In Poland, there is a continuously present specialist in anesthesia and intensive therapy or anesthesiologist. This is somebody who, an old version of our specialization, only one part. There were two steps, and anesthesiologist is somebody who just had one step done. So it's not fully qualified in terms of exams, anesthesiology specialist, but those anesthesiologists are already at the age of retirement. So right now we have almost only full specialists in anesthesia and intensive therapy. And when they are working in the post-anesthesia care unit, they cannot work in the ICU at the same time. So there must be an extra doctor just for post-anesthesia unit. And the doctor is usually close to the anesthesia, this unit, post-anesthesia unit. Direct supervision is performed by anesthetic nurses. If something needs to be done, some drug must be ordered, or the patient must be discharged to the general ward, then the nurse asks doctor to sign the documents, to look at the patient. There should be no less nurses. The ratio nurse to the patient to the occupied bed should be no less than 1 to 4, and there must be a lot of place in this. There should be a lot of place in this post-op anesthesia unit, so there should be easy access to the patient's bed from every side. Just for you to know that the anesthesia recovery room has some safety precautions, and in the documents, in the official documents in Poland, there is written exactly what should be the recovery or post-anesthesia care unit equipment. So there must be CPR trolley with possibility of cricothyroidotomy, defibrillator with cardioversion possibility, at least one ventilator with regulated of FiO2 between 21 and 100%. In our hospital, it's not at least one, every bed in the post-anesthesia unit has a ventilator. So it's really much more than just basic requirements. Every bed, post-anesthesia bed, should have source of oxygen, air and vacuum, blood pressure apparatus, ECG monitor, pulse oximeter, thermometer. So cardio monitor is at every station. At least one suction pump for 3 beds. We have every bed has suction pump in our hospital, and there might be possibility to opt to direct observation with camera, especially observation of patient's face, if the patient agrees to being monitored. And the recovery room discharge criteria are strict. From the safety precautions, the patient must receive 9 or more points in this modified Aldred scoring system to be safely discharged to the general ward from the operating theater. So the patient must almost be able to move, had no problem with respiration, no problem with, no serious problem with circulation, should be conscious, and with good oxygen saturation. So to have 9 points, you need to have maximum at least in 4 categories. So you have to have 4 times 2 points and in one category 1 point. So it's really safe. This is the safety precautions. And so it was about the operating theater. Now a few words about intensive therapy units. In most countries in English literature, these units are called ICU, intensive care units. In Poland, it's also mostly called ICUs, just so people know what we are talking about, but generally they should be called intensive therapy units. So sometimes in this presentation there is ICU, sometimes it's ITU. This is the same. What is the meaning that in Poland, the difference between ICU and ITU, intensive therapy unit, is that in the ICU, intensive care unit, is mainly about care, nursing care, not a treatment, not a therapy. So it's better to call our, the direct translation from Polish would be intensive therapy unit, because we do not, it's not only care, we treat the patient. But you know, this is for make it easier, just think that ICU is the same as ITU. And the story of ICU in the worldwide started in Denmark. In 1952, there was an epidemic of Medina disease, polio disease, and many young, especially young people, were unable to breathe because of the muscle paralysis. And they were first ventilated non-invasively, then they needed invasive ventilation with trachea intubation, and there were not enough ventilators. So students, medical students, young people were ventilating those patients 24 hours for 24 hours for 7 days a week with self-inflating bag. They were changing, of course, after a few hours, because nobody can do it for all the time. But there was the necessity of ventilators around and the necessity of units that can provide treatment for such severely sick patients. And creating ICUs increased chance for survival of the critically ill patients. So this is the explanation why sometimes it's an ICU, sometimes ITU. And generally ICU is an assigned ward with own head of the ward, own staff, and own budget. So we are a part of a hospital, independent of other units in formal way, but we need help of other specialists. We need availability of devices that are stored in other units. We need availability of imaging, radiology imaging. So we cannot work without cooperation of other unit, other specialists. But if we do not need help, then we are really independent. It can be different if the organization of ICUs might be different in different countries. So in Poland, ICU is led by specialists in anesthesiology and intensive therapy. If I need surgery, surgical consultation, I ask the surgeon to come. If I need an echocardiologists, I ask cardiologists. So they are just coming and performing a consultation. ICU pays the clinics of surgery, the clinics of cardiology, fee for the consultation. In other countries, it's possible that there is an intensivist working in the ICU, not anesthesiologist, just intensivist. And it's possible that there are some intensivists working. So pulmonologist may be part of the ICU, cardiologist, surgeon. It depends on the country. It doesn't matter which country, the special people who work there must be skilled. Doctors must be skilled, nurses, there are dedicated nurses in the ICU. They work only in the, some of them work only in the ICU. In some hospitals, there is a rotation between the anesthesia and ICU. It depends on the organization. Equipment is just for the ICU, and we need space. We cannot work in a small rooms. We need space. And the requirements for the ICUs are in the decree of the Ministry of Health about standards in organization of care in anesthesiology and intensive therapy. So there is a law which says how ICU must be organized. And in this document, there are appendixes. And for instance, in the one of appendix, it's written, what are the general requirements for the unit? So there must be some conditions fulfilled. Staff organization of providing medical services. There must be equipment for the ward as a whole one unit and for a single bed. Must be space, and some other requirements might be necessary. In the part 2, there are details condition for the ICU depending on the reference level. How it should be organized, what equipment is necessary, how many nurses, how many staff is necessary. The patient in the ICU is treated in a kind of modules. Module is a bed and everything that surrounds the patients. And this module, this bed, its surrounding must have everything necessary to monitor healthcare function, to perform some urgent interventions like intubation, for instance. So basic equipment is at the patient bedside. The general equipment for more complicated intubation is on a special card, which we have 2 cards for 12 beds. So if something's right at the patient side, at bedside, some devices, some equipment available for the patient, but not stored at the patient bedside. The floor space is necessary. Enough space is necessary. So this unit equipment for the equipment for the unit may differ between the countries. I wrote here just to show you what is the minimum necessity in Poland. So suction pump electric, at least 1 per 3 beds, no less than 2 per unit. We have suction pump at every bed, so much more than necessary. Cardiac output monitor. This is not just the simple monitor that you have in surgery, in the operating theater. This is the monitor which allows to measure more invasively, more detailed heart function. At least 1 for 4 beds, we have more. CRRT device. CRRT means continuous renal replacement therapy. So this is the apparatus that allows us to perform treatment where kidneys are not functioning. And we perform continuous treatment. We very seldom perform intermittent hemodialysis. We perform 24 hours for 24 hours treatment. At least 1 bed, if no IHD, is intermittent hemodialysis. So at least 1 for 8 beds. We have right now 6 devices, and we have our two units. So in 2 our units we have 16 beds. and 6 devices per 16 beds, so much more than necessary. Flexible bronchoscope, at least 1 per unit, we have more. ICP monitor. ICP means intracranial pressure monitor, at least 1 per unit. We have at this time 5 of these monitors. X-ray apparatus, at least 1. Yes, that's enough. We have 1. Defibrillator, at least 1. We have 2. Transport ventilation, at least 1. We have 4. Then it's written what should be at every bedside patients. So there must be special mattresses which prevents pressure source, because the patient in ICU stay there for a longer period of time. So, and they are at very high risk of pressure source, so we need to prevent it. Ventilator, source of electricity, oxygen, air and vacuum, kit for intubation and ventilation with self-inflating bag, devices not necessary for infusion, so electric infusion pumps, systems for regulated infusion, at least 6 pumps per bed. Cardio monitor, pulse oximeter, capnograph. Pulse oximeter very often is incorporated in the cardio monitor. Capnograph might be a part of ventilator. It might be an external device. It depends. Apparatus for non-invasive blood pressure measurement, for device for invasive blood pressure measurement. Mattresses or other devices for active regulation of body temperature. We have a external device that pumps warm air into the blanket. So this is a special active warming device. Stethoscope. And so every bed should have their own stethoscope. There is no, so it's because it's safe for the patient to use the same stethoscope for the patient. So we do not risk transmission of bacteria between the patients. There should be ultrasonograph in the unit, critical parameter analyzers, so we don't have to send blood samples to the lab, to the central lab, when we need some parameters from the blood. We can have blood gas analysis. We have hemoglobin and hematocrit, electrolytes, lactates, glucose, blood gas analysis, I've said, acid balance analysis, and it's possible to have also creatinine for assessment and procalcitonin, creatinine for kidney function, procalcitonin for infection status. So we don't have creatinine and procalcitonin, but the other parameters can be measured within the unit. It takes 3 minutes. Instead of taking the blood, going or sending to the central lab, waiting for somebody to perform the analysis, waiting until this person accepted in the central computer and send it to the system so we can see the result on a computer, on a monitor. It takes at least half an hour. We need results immediately, so we have the analyzer in the unit. And as I said, some devices, some kit for difficult airways. It's also said how many nurses should be in the unit, working in the unit per shift, depending on the level of the unit. So first level is a level with minimum 4 beds, second minimum 6, third minimum 8 beds. And the final, it should be that in the third, this is our third level, 1 nurse per 1 bed per shift. This is not obligatory yet, but in the future it will, I'm sure we will have to follow the rule. For the moment, we have always 1 nurse per 2 beds per shift. This is enough. And but there are also, in different countries, it may be organized differently. It's possible, but I think it's in Norway, that the number of nurses depends on the patient's condition. So if the patient is not intubated, it's possible to have, let's say, 2 nurses, 1 nurse per 2 beds. If the patient is intubated, 1 nurse per 1 bed. If the patient is on the extracorporeal treatment, then one extra nurse or two nurses per patient. It depends. And also in some countries, there's someone like not nurse, but the helping person, somebody who takes care of the patient, washes the patients, makes, helps to lift the patient. In Poland, all this is done by the nurses. Nurses take care of the patient, nurses take care of the drugs that are given to the patient, they give the drugs, they perform the documentation. In some countries, nurses only prepare the drugs, monitor the patient, and fill in the documentation. All the dirty part of the work is done by somebody who is not a nurse, who is lower in the hierarchy. We don't have this commonly in Poland. In some units, yes, I know that in general units in our hospital, there are some such people who help the nurses. In the ICU, we don't have someone who's called help nurse or helper to the nurse. Our ratio of nurses to the patients, it's not so far from the general, from the American, let's say. See, in United States, the proposition of intensive care ratio of patients to the nurse is 2 nurses to 1 patient. The same in the neonatal unit. So two nurses for 1 nurse per 2 patients is quite nice. I said that we need space for the patient's bed, and it's also written in this legal documents. First, if the patient in the ICU is treated in the single bedroom, the space should be at least 18 square meters. If it's a multiple bedroom, like we have in our unit, at least 16 square meters should be left for one bed, each bed. So if there is 10 beds in a room, there must be 160 square meters just for the unit. So it's a lot. And number of ICU beds within the hospital should be at least 2% of all hospital beds. In Poland, it's not achievable in most hospitals. So what we do in the organization of work in intensive therapy must be very precise, must be strict. Everyone should know what he or she should do with patients. So what we do, we support the function of vital organs, and we provide the treatment of the patients who are in danger of life condition, who are unstable, who are in critical condition. And to make sense, the treatment makes sense if the condition is caused by potentially reversible insufficiency of one or more basic vital organs. If it's non-reversible organ insufficiency, intensive treatment may become futile. We focus particularly on deterioration of respiratory, circulatory, central nervous system. And again, it can be different, the situation can be different in different countries. In Poland, there is not much ICU beds, so we admit patients in more severe condition compared to some other countries. So sometimes there are movies, American movies, when the patients, when they are shown patients in the ICU. Of course, some of them are intubated, mechanically ventilated, but some of them look really relaxed. So they are just in a less intensive unit. So in Poland, they are treated in the intensive care unit because they need special monitoring, special systems for eventual deterioration that will be used in case of eventual deterioration. In Poland, we admit the patients who already require intensive therapy. Patients suffer from different diseases. They have potentially reversible threat to life. There must be qualified staff working in the ICU, and there must be adequate equipment to provide treatment. And before we admit the patient to ICU, we have to qualify the patient. We have to say this patient is eligible for ICU or this patient is not candidate for ICU. And the qualification criteria are written, and we just have to follow the rules, which are written by Polish Society of Intensive Care, of Anesthesia and Intensive Therapy. We admit the patient from the different wards in a hospital, from emergency department, and from other hospitals. If the patient is too sick for the ICUs of the lower level. So for instance, we have the device, the equipment that is not available in ICU in small town, then the patient is admitted to our ICU. Main criterion is the severity of patient's condition, and there are some and as I said, prioritization must be done before admission. So the first group are the patients who have direct threat to life, mainly because of reversible circulatory and or respiratory pathology. So those patients will gain the most from the treatment, and we should provide them everything that is possible. So the highest treatment level. The second priority is this person who needs intensive monitoring, which can be given or delivered only in the intensive care because they may deteriorate or they may need invasive techniques of treatment that can be done only in the ICU. So these are patients in relatively good condition who may deteriorate. Admission priority 3 is somebody with physiological status before deterioration or at the moment of qualification so severe that it significantly decreases the chance for recovery. So the benefit from intensive therapy is rather low. We often disqualify the patient from this group. And the fourth admission priority is the one where intensive therapy is unjustified. Eventually, these patients may be admitted as an individual decision of the head of the ward or somebody who is in charge. So these are patients who are too healthy for intensive therapy. So because they are too healthy, they will have no benefit of intensive therapy, but they require a procedure that can be done only in the ICU. Those patients usually sometimes we admit, sometimes we don't, it depends. Sometimes it happens that this procedure finally can be performed outside the ICU because the admission to the ICU has also risks. We have bacteria which are resistant to some drugs, so the patient, antibiotics, so the patient is always at the risk of acquiring the bacteria, be colonized by the bacteria that are in the ICU. Or patients who are too sick with incurable terminal disease. It doesn't make sense to give intensive therapy to somebody who is in a terminal condition. So those patients we usually disqualify. All the modern techniques are used in the ICU. As I said, we ask other specialists for consultations. When the patient no longer needs intensive therapy, we discharge the patient and the treatment is continued, not so invasive treatment on another ward in a hospital. If you will be the person responsible for planning, creating a unit, then you will have to follow some rules. These are quite old rules, but they give us good information what is necessary. Our ICU must be planned correctly, designed to make patient admission, staff visitor traffic patterns easy. Must be a place for support facilities. ICU must be in a close nearby to the operating theater. We should have easy access to radiology. So in case of necessity for radiology, we just go one in our hospital. We just go two floors down using elevator, which is in our unit, in fact, close to our unit. 8 to 12 beds per unit makes sense. Lower number of beds doesn't make sense because the resources are very high for the unit, and if there's only 4 beds, this is not economically logical. You pay too much for creation, in contrast to the low. It will be. It will be a very expensive, the creation of small unit, and you will not get much money from those who pay for the treatment in Poland is National Health Organization, something like that. There must be isolation room. There must be the unit must be closed, so there cannot be through traffic to other departments through the unit, and we should be not easy accessible for public or visitor traffic. There must be there must be an isolation room for adults or children with the sluice for hand washing, a place where we can change clothes, and the place where we store contaminated materials. So we have 2 isolation rooms. In Poland, it must be led by the specialist in anesthesiology intensive therapy. Specialist is there 24 hours a day for 7 days a week. The same with anesthetic nurse, 24 hours to 24 hours, 7 days a week. And there must be a central nursing station, so the nurses can work there and see the patient faces. If the patient face is inaccessible because the patient is in the isolation room, then there must be a camera showing the patient's face and the patient's surroundings. And what we do in ICU, we perform basic monitoring of the patients. It's just written here: ECG, blood pressure, central venous pressure measurement, intracranial pressure measurement, some measurement in the pulmonary artery, cardiac output measurement. We assess the patient's airway, we ventilate the patients, we perform bronchoscopy. We give fluids, we suction the airway, we perform renal replacement therapy, we can perform simple imaging techniques like X-ray or ultrasonography, we defibrillate, perform cardioversion, external pacing, we monitor the patient's condition. And in some more high level of ICU, there must be, it doesn't have to be in every unit. That's why some patients are transferred to our unit, as I said, from smaller hospital. Videoscopy, we have, videoscopy is bronchoscope with a big monitor. Extracorporeal light support, some methods of mechanical support, extracorporeal gas exchange devices, treatment with nitric oxide, thromboelastometry, this is the measurement of coagulation, ability to perform therapeutic hypothermia. It doesn't have to be in every unit, so this is something additional. ICU bed as a bed is higher and wider than the standard bed. It must allow easy access from at least 3 sides. Must have heart-based bases. We use it for the transportation within the hospital, and it must allow to change the patient's position, to keep the patient in different position. And ICU nurse is not a typical nurse. This is the nurse who is always under the stress. she or he may have ethical problems because the patients are many patients are at the end of their life. We have a lot of the mortality in ICU is rather is higher than in another units. There are some legal factors, legal problems, like patients are unable to give a written informed consent. So there is some activities that we do. We should get the patient sign consent, but we cannot have it because the patient is unconscious. There's a lot of paperwork in Poland for nurses, for ICU nurses, high physical work because there is no one who can help the nurse. They help each other. It's a teamwork. It's impossible to work individually. Nurse assistants in rich countries. In Poland, we don't have, or volunteers, so it's possible to have less work, but in our country, it does not exist. The patients are unconscious, so in most cases, they are not helpful. So they're very heavy. They are totally in 100%. They rely on nurses, so they cannot move themselves. They have to be moved, and they have no anatomy. The nurse in ICU is continuously present near the patients. We doctors, we are not all the time at the patient bedside. We are sitting in our rooms, we are writing documentation. Nurses are always near the patients. They need to communicate with the patients. They assess the patient's consciousness level. They assess the patient's pain level. If the patient is cooperative, or if the patient is not cooperative, they observe the patient. And they have to prevent the complications like pressure sores, infection by changing the patient's position, by suction the airway. And some hospitals are trying to decrease the costs by not employing nurse assistants. So decreasing the costs often increases the workload of the nurse. It all causes the stress. At the end, I want to show you how it's possible to organize the hospital. There are traditional ICU departments and mixed ICU departments. So the patient is treated in different units. Then the patient requires intensive care. Post anesthesia, the patient go to high care post surgery, post anesthesia unit. Don't look at this. Then the patient after intensive care goes to the medium care unit, kind of step down unit. And after, when the patient is in a much better condition, is transferred to the general ward. In Poland, we have the patient is admitted from general ward, from surgery, from neurology to the ICU. There is no medium care. The patient after ICU goes straight back to his own unit. This is here you have in this traditional ICU department, you have intensive care units for every surgical. This is neurological intensive care, gynecologic intensive care, internal intensive care. So different types of intensive care. We have mixed intensive care. So in our unit, we have patients from different divisions, from different wards. We don't have medium care. So the patient after ICU goes back to his own unit. So the organization, there is no, the hospital cannot exist without the ICU. The hospital cannot exist without the anesthesiologists. So we have to keep in mind that we are really important group within the hospital, but we have to keep in mind that we are not, that we need help, that we need consultations, we need to perform imaging for our patients. So, however, we are an autonomic unit, but we cannot close the door. The door must be open for other doctors, other specialists. Okay, any questions? If no, I will now talk a few words about infection prophylaxis. The presentation is based on a Polish program called Antybiotyki Edu.pl, which and our hospital epidemiology procedures, as well as the Ordinance of Ministry of Health from 2016. ICU is a dirty unit. I mean dirty because of the bacteria, because of the potential pathogens. We are very clean. It's the person responsible for cleaning are cleaning the floor, everything all the time. But unfortunately, bacteria exist. Patients have bacteria which are and in ICU we treat the patient with drug-resistant bacteria, and it's always risk that the patient gets the bacteria. It's because of the antibiotics that we give to the patient. We give antibiotics, bacteria are fighting against the antibiotics, and the patient may get the bacteria, which is drug resistance. There are reservoirs of pathogens. There are routes of transmission between the patients, staff and patients, environment and patients. The surfaces can be source of pathogen, causing hospital acquired infections, and generally there's a risk of infection when you are in critically ill condition. Humid environments or dry air are reservoirs for different bacteria, so there's a risk of being an epidemic source. Unit can become an epidemic source of bacteria within the hospital. And this infrastructure of ICU is complicated. There are other factors that increase the risk. So but it's hard to determine the link between this infrastructure and the risk of hospital-acquired infection. It's necessary to, when the project of the unit is being done, it's good to consult it with the specialist of hospital infection, just to create a unit which is easily accessible for cleaning. So this is the knowledge that some specialists of hospital acquired infection should have. ICU, there is an isolation room with Lewis, which work in two ways. The isolation room can isolate the patient from the surroundings, from the bacteria, from the viruses that are around. So this is the patient with decreased immunological condition, like hematological patients, needs to be isolated from other patients. And the second idea of isolation room is to isolate other patients from the person who is in the isolation room, like somebody with influenza. So to decrease the risk of spreading influenza virus to another patient, we put the influenza patient in the isolation room. So the patient is a danger for other patients. When there is a respiratory airborne pattern pathogen, there must be a negative air pressure room. In our unit, we have possibility to change the pressure from negative to positive. So for COVID patients, there should be negative rooms, isolation rooms, because this is an airborne infection. We don't want the airborne infection to be spread outside the room. So there must be a suction, negative air pressure within this isolation room. There must be many hand disinfectant dispenser everywhere in the unit, so it must be easy to wash, to disinfect the hands. We have these disinfectants at every bed, and several are located on the walls of the unit. Also, soap disposers must be decontaminated. Hand disinfectant disposers must be disinfected. Containers for paper towels must be disinfected. So this everything must be disinfected, and the water intakes must be decontaminated. If there is a place when you perform dirty, contaminated procedures and clean procedures, they cannot be connected. And if you do if the patient must have if a contaminated procedure must be performed and clean, always clean is done first. So first take care of the patient's wounds, then take care of general washing the patients. Everything should be easy to be decontaminated. Cleaning teams should be trained regularly. Generally, it's good to have one team which works in your unit. We have it. The cleaning teams in our unit is a group of these are two people who work only in our unit. They don't go to the surgery, they don't go to another unit, or even if they go because they are sent there by their boss, no, they can, there is only they work in our unit. So I'm not interested what they do after hours, but in our unit, only this team cleans, disinfects the surrounding. There is no such situation that somebody from surgery comes and takes care of cleaning ICU. No, it's always the ICU cleaning team. And it should be, the performance of them should be controlled by observation and by checking with fluorescent indicator whether the surface was cleaned or not. It's possible just to use some control measures to check whether the surface was cleaned or not. It's a job of epidemiology nurse. If something is decontaminated, then should be stored in a place where it's safe, when there is no risk of contamination. So clean devices should be kept in a clean room. No, they cannot have contact with contaminated things. Hand hygiene. It's the most important way of prevention of hospital-acquired infection. If the patient who is lying on the bed number 1 has a bacteria, and then a few days later, the same bacteria is isolated in the patient's of bed number 2, it's the only solution is that this is the staff who transferred the bacteria. The bacteria cannot jump. It's impossible for them to jump from bed to bed, but it's possible that we have the bacteria on our hand. Without proper hand hygiene, we will give this bacteria to another patient. So this is washing the hand, performing hand hygiene is a way of stopping the transmission between the bacteria between the patients. We use disinfectant alcohol-based hand rub. We don't use water and soap routinely. Water and soap has to be used after the contact with Clostridium difficile patients. There's only one bacteria which requires washing hands with water and soap, because standard alcohol-based solution is not effective. We wash the hands with soap when the hands are apparently dirty, because alcohol does not remove dirt. And we have to wash hands after using the bathroom. So this is no exceptions. If we use alcohol-based disinfectant, we shouldn't use it concomitantly with soap. Only for disinfection, only alcohol. For washing, soap and water. And if we would use these two methods at the same time, so regularly wash hands with soap and then use the alcohol, then there's an increased risk of skin irritation, and very often we want to do it rapidly. So we don't wait for the water to dry, for hands to dry, and it's risky that we use alcohol on not dry hands, and the concentration of alcohol will be decreased and effectiveness of alcohol will be also lower. So hand hygiene means alcohol-based solution is recommended before and after contact with patients, after the contact with patient's surroundings, bed and everything that is near the patients, before some procedures that are at high risk of infection. We have to, when we perform catheter placement, peripheral vascular access placement, or invasive procedures that do not require washing with soap, we use alcohol and gloves. So if using the gloves doesn't mean that you can not disinfect hands. Hands must be disinfected before and after putting on the gloves, and before preparing drugs. After contact with secretion, mucus, damaged skin of wound dressing patients, during care, if the procedures have been done in contaminated areas, they must, before you touch clean areas, it's always obligatory to use clean procedures before the contaminated procedures. After contact with patients devices, medical devices, and after gloves removal. I will not go through the technique of hand washing. You will learn it later. This is the very good World Health Organization picture showing where you need to use hand hygiene, when to use alcohol. Before touching the patients, before clean aseptic procedures, after exposure to the patient's body and fluid, after touching the patients, and after touching patient's surroundings. So generally, before you go to the patients and after you leave the surrounding, use clean hand, use hand hygiene. This is, I will also skip, you will learn it later. Sometimes you may use sterile gloves, sometimes you may use not sterile gloves. Non-sterile, generally, the indication for sterile gloves is when you perform aseptic procedures. All the different, the rest of the situations are indication for non-sterile gloves. Generally, when you touch the patient and there are no fluids, you just want to take the patient's pulse, there is no necessity to wear gloves. But when the patient is isolated, yes, it is necessary, because when you know that the patient has a special pathogen, then everything must be done in gloves. Using gloves cannot replace proper hand hygiene. This is the most important thing. Should be put before entering the patient's room, must be put and taken off right after the procedure. You cannot use the same gloves for care of more than one patient. And you should remove the gloves immediately after the procedure, immediately when you leave the patient. You have to put the gloves into the special basket, into the special container, which is for container for contaminated things. And if you do, as I said, clean areas treatment, you have to change gloves between, and if you do something with contaminated area, then you cannot touch the patient, you cannot touch the patient surrounding with the same gloves. And if you do contaminated and clean areas, always clean areas before the contaminated. So remember that when you have dirty gloves, you shouldn't touch anything which is not necessary. And always never touch clean surface, clean patient's area, clean patient's part of the body with the gloves that you used for contaminated procedures. Because when when the patient, as I said, when you want to check the patient's pulse, when you want just to take the patient's hand, it's not, and the patient is not contaminated by multi-drug resistant bacteria, you don't have to wear the gloves, because when gloves are used too often, there is a risk of allergic reactions, especially when latex containing gloves are used. And people have to remember about disinfectant, using disinfect alcohol for disinfection. If you do everything in gloves and you forget disinfecting the hands before and after using the gloves, then the idea of proper hand hygiene may somehow disappear. So the most important thing is to remember that hand has to be disinfected. For some procedures, you have to use non-sterile gloves. For some procedures, you need to use sterile gloves, and always before and after using the gloves, hands must be disinfected. If it's Clostridium difficile, the hands must be washed with water and soap. And if not necessary, do not touch the patients, do not touch the patient's surrounding. Don't take your personal items to the isolation room or when you take care of patients. It's good not to have your telephones in the isolation room, identity cards, key lashes. It should be, if you have it, it should be kept in hidden in. So there is no risk that suddenly your keys fall into the patient's bed, and then they will need to be disinfected. We have to remember that there are some places which are difficult for this, not we, the cleaning teams, that are difficult to disinfect, and we should, like consoles, computers, and we should remember that before we touch the computer, before we touch the consoles, we have to disinfect the hands. If we have bacteria and we touch the keyboard, then the bacteria will stay on the keyboard, and the person who will come next will touch it again and will have it on your hands. So that's why it's very important to disinfect hands before and after contact with the patients. What is also important is to dress correctly. This is incorrect way of dressing. Some hospitals have dress code policy. We need to have short sleeves. We should avoid wearing ties and hospital gowns with long sleeves. So maybe these people look nice, elegant, but this is not how they should be working in the ICU. Generally, also in surgery, they should not look like this. This is the way that we should be dressed. Short sleeves, nothing on the wrist, so we can easily disinfect the hand. Short head, short hair, or if long, they must be kept behind. And we shouldn't, and we should change every day our clothes. So that we should, so every day we should put on the clean new clothes, new scraps. And it's similar in the operating theater. It's even more in our hospital. It's even more there are more rules for the operating theater. In ICU, I can have my own scrap. In the operating theater, I have to put on the scrap, which is provided by the hospital. And after the day of work, this scrap goes into the washing machine somewhere. This is, I'm sure that it is 100% sure that every person every day will have a clean scrub. visitors in the ICU doesn't have to work to, if the patient is not isolated, they don't have to, the families, they don't have to put on special gowns in our hospital or special scrubs, not. But we ask the consultants who come from other units to put on the gown just to prevent them from transmission of the bacteria from surgery, from general ward to our patients, and to help and to prevent them from taking our patients' bacteria to their surgery or general ward. But there is no need to use a protective clothes by the families, by the visitor, except when the patient is really isolated. We have to give the families the information that they need to decontaminate the hand before and after. They must use the same precautions as we do. And there's no, from the epidemiological point of view, it's not recommended to restrict the visiting policy in the ICU, except when a visitor has an infection. But COVID changed everything. Yes, there was no visiting possibility due for several months. Now we allow vaccinated families to come to the patients. Isolation in ICU is done in some situation. As I said, when we want to isolate the patient from other patients because the patient has has low immunological condition, has altered immunological condition, or we want to isolate other patients from the infectious patient. It's very important in immunocompromised patients. Isolation, how long? I don't know, it's not determined. From admission to discharge or for until 3 consecutive microbial cultures within 2 weeks and around 1 week after termination of antibiotics do not reveal pathogen that was the reason for isolation. However, there is always risk of not final eradication of the bacteria, so it's possible that we have negative results. No bacteria in a lab result, in a result, but the bacteria is still there. But at the moment of checking it, there were other bacteria who were, let's say, more strong and suppressed this dangerous bacteria. So sometimes it's safe to isolate the patient from admission to the discharge. There are some specific situations when there must be longer isolation, like till the end of hospitalization. So this is especially performed for dangerous bacteria. Pathogen mechanism, there are different types of isolation. If you are not compliant with the isolation rule, the isolation will not make sense. In the isolation room, there must be minimum devices because everything must be then thrown away after the patient leaves the room. So it's not good to have a lot of devices there because it's a cost. It costs. So everything goes to the trash after the patient leaves the isolation room. I mean, single-use devices, and there must be appropriate personal protective equipment used depending on the isolation type, and we have to use the equipment correctly. In the isolation room, personal items cannot be used, documentation cannot be taken into the isolation room, one stethoscope for patients. If not, then disinfection must be very, very crucial. Whole device must be disinfected. We can cohort the patient with the same pathogen, so it's possible if there are 2 or 3 patients with the same pathogen, they can be cohorted in one room. If there's isolation, number of visitors must be minimized. and personal equipment, personal protective equipment must be taken on and off right before entering and right after leaving the area, followed by hand disinfection. In case of infection caused by several bacteria and some viruses, droplet isolation is necessary. We have to wear surgical masks, glasses in case of action that cause aerosol formation, and single room or at least 1 meter between beds with curtains is safe. For airborne isolation, the protective equipment is special, and we have special masks. We have to have a gown. We need to have precautions on the eyes, so gloves or shields. We've learned it a lot during the SARS-CoV-2 pandemic. And this is just to show you that we have in hospital, every hospital has some instruction what to wear, what to put on in terms of personal protective equipment, depending on the procedure that we perform. The most common isolation in a hospital is a contact isolation. It's used for infection, diseases, or germs that are spread by the touching the patient or items in the room. So the contact isolation is for the most common bacteria used. And we have to wear gloves and in some cases a gown just to prevent the transmission of the bacteria. MRSA, VRE, these are the bacteria which are resistant to drugs. Diarrhea, illness, open wounds, respiratory syncytial virus, those patients might be in contact isolation. This is I will skip. And in a hospital, there should be instructions, special procedures created for nurses, for doctors, describing how we should act when we perform those procedures who are at high risk of transmission of bacteria and when infection might be dangerous. So we have a procedure saying how to prevent infection when we put central venous catheters. There are procedures on prevention of ventilator-associated pneumonia, so how to perform suctioning, for instance, how to put on the urinary catheter, how to treat the patient with the urinary catheter to prevent the patient from infection. And the hospital may have different procedures created, and also hospital needs to have something called perioperative antibiotic prophylaxis politics or antibiotic politics. In perioperative antibiotic prophylaxis politics, there is a list of operations and it's written which antibiotics should be given before the operation and for how long. Some operations require only 1 dose of prophylactic antibiotics, some require 1 day, some require very seldom 3 days of antibiotic prophylaxis post-operatively. And we also have politics saying which antibiotics should be used for different, depending on the infection. So for pneumonia, if the patient is admitted to ICU, use ceftriaxone plus doxycycline doxycycline, or you can use piperacin plus tazobactam and doxycycline. So it's or clarithromycin. So we know what antibiotics we use empirically without knowing the bacteria when the patient is admitting to the ICU. What we also do is we check the patient's colonization status on ICU admission. So we check what bacteria patient have in nose, in digestive tract and in the airway. So just to know what is the epidemiological patient's condition. In operating theater, Louis checking, changing the clothes, changing shoes, the apparel, the pants. Outside the operating theater, doctors should wear white scrubs, nurses light color scrubs. In the operating room, we have different colors in different operating rooms, but generally every operating room has one color of the scrub. So you know that if somebody with green clothes is somewhere on the hospital corridor, you know that this person shouldn't wear this green because this is the color reserved for the operating theater. So this is the different colors politics. No operating room scrubs outside the OR. Short nails, no artificial nails. Jewelry must be removed before going into the operating theater. Everything that hand hygiene must be done, nothing on the forearms, hair must be tied. If there's injury to the skin on hands, the waterproof dressing must be used. There must be special shoes for operating room only and socks only for the use within the OR. After scrubs are taken from the dispenser in the sluice, shoes are changed in the sluice, cap put on, head cap on in the sluice, and surgical mask is taken from the box in the scrub room normally before entering the operating theater, the operating room. But during the pandemic, we wear masks all the time. So this rule has changed. Normally, we had to use cap, shoes, and scrubs within the whole operating theater, and the mask only when entering the single operating room. Now we are wearing it all the times. And the precautions are very, very important. Any questions? Some of these procedures you will learn so don't worry that I was going very, very fast through the hand hygiene, hand washing, because you will learn it practically in the future. I just wanted to show you that some precautions must be made, and what we have to do. Many will, as I said, will be easier for you in a practical things in next year or in next 2 or 3 years. So the last subject, totally different, it's rather clinical, is an assessment of consciousness level in the ICU. We have patients with very different stages of consciousness in the ICU, but those patients with different levels of consciousness can be also found in different wards, in emergency department, in surgery, in neurology. In ICU, we additionally give the patients drugs, sedation, that changes their consciousness level. So we have kind of iatrogenic change of consciousness level. However, some patients have pathology that is the reason of this altered stage of consciousness. And on one side, it's very important to be able to evaluate the state of patient's condition in the ICU, because we need to have this information for the treatment. But on the other hand, by giving the drugs, we totally change, we turned off this possibility, in fact. Because when the patient is deeply sedated, it's impossible to say that something changes in patient's awareness or consciousness. Awareness means that the patient is vigilant, have thoughts and feelings of an individual person. Brain is ready to react, but it's not as good reaction as in the consciousness. So awareness is lower than the consciousness. Somebody who is conscious understands what's going on, realizes something, but also can record it, analyze, react intentionally to various stimuli. Someone who is aware will not do that. The patient who is conscious, we are conscious, I hope, are feeling, we feel emotions, we can perceive, we keep the attention, we can use our memory, everything is normal. We can speak, we have emotions. Our brain is is able to see the reality, realizes what is going on. So consciousness is full capacity, using the full capacity of the brain. Awareness is just is less. You know you are ready, but you do not use the higher possibility, higher level of analyzing, recording, etc. Consciousness can be altered because of primary or secondary reasons. The primary is that something has happened to the nervous tissue in the brain. So the brain is injured first. And secondary alteration of consciousness means that something happens outside the nervous system and it influences on the functioning of the brain. And so hypoxia, infection, toxic drugs, hypertension may lead to something called encephalopathy, pathology of the brain. Seizures, cerebrovascular accidents like stroke, it can lead to the changes of consciousness. Hypercapnia means too much CO2 in the blood will cause the dilation of the intracranial vessels and the patient may fall asleep. And we also can create the alteration of consciousness, usually decreasing. We decrease the level of consciousness by giving the patient drugs, sedation, or anesthetics during anesthesia. When we think about the consciousness, we assess the level of consciousness and the content of the consciousness. Everything must be working correctly to be aware. And the integrity of the cortex and subcortical connection is necessary for awareness. There is also something called arousal. The patient who is aroused is someone who is awake. But the patient who is only awake may not be cooperative. The arousal means that reticular activating system and upper brainstem are working correctly and they have connection to the cerebral hemispheres. Depression of the brainstem or hemisphere function may lead to reduced arousal, reduced wakefulness. So we assess some reflexes to check whether the patient is aroused or not. The brainstem is the heart of the brain. If the brainstem is not functioning, the brain will not function normally. Because in the brainstem there are sources, there are the proper function of visual, of hearing, motor tone and motor function, autonomic control depends on good function of reticular activating system, which is located in the brainstem. So without the brainstem, we will not see, will not listen, hear properly, motor function, tone will be changed, autonomic control will not be effective. Consciousness disturbances may be quantitative or qualitative. Quantity, if there's a quantitative, it means something happens in the brainstem. If it's a qualitative, it means something happens in the cortex. Normal patient, we are normal. We, in Glasgow Coma Scale, we receive maximum points. We can be somnolent, we can be in stupor or in coma. Somnolence is, you can imagine that someone who is somnolent is someone who is falling asleep. When we are tired, we are falling asleep, we feel drowsy, we have difficult to be aroused, we fall asleep, reactions are normal, reflexes are present. If somebody tells us, open your eyes, you will open your eyes. You can move yourself, you can change position. Muscle tone is rather normal, or if there is another focal deficit in the brain, it can be not normal, but generally normal somnolence, not in a somnolence, the muscle tone should be normal. When there's a stupor, there is no vigilance, no spontaneous movement, the patient is like frozen. The patient does not modify body position. However, when we give a pain stimulus, the limb will be withdrawn. So the person will try to run away from the pain. Eyes are closed. When open, if they open the patient's eyes by lifting the eyelids will close. And muscle tone is also normal. The worst condition is coma. It's a state of complete unresponsiveness. The patient has no vigilance, no reflexes, muscle tone might be increased. There might be pathological movements called decortication of the cerebration. I will show you how it looks like in a moment. There might be problem with breathing pattern, and the patient may present brainstem pathology symptoms, yawing, hiccup. This is normally we may have hiccup, we may need to yawn, but patients who are in coma, they do it in a pathological way. In somebody in coma, yawning and hiccup is a bad sign. Usually coma lasts it can last 1 to 6 hours, so at least then you can say that the patient is in coma. If it lasts 10 minutes, it's not coma, it's something else. And usually coma lasts up to 2 weeks if there's no other illness. So the clear coma, 2 weeks, and later, after 2 weeks, either the patient will get better or will stay in vegetative state. Yes, this is something, these are the pathological movements, the pathological signs when there is damage, severe damage to the brain. The patient may extend limbs, it's called decerebration, or the patient may abnormally flex, usually hands. It's called decortication. Decerebration, extension, means that there is severe damage, severe to the brain. If there's decortication, means that there is a damage to the nerve pathway between the brain and the spinal cord. However, sometimes these signs may pass, and sometimes they will not pass. What are the coma causes? Intracranial or extracranial? Yes, so trauma or something, or stroke within the brain, or toxication, hypoxia, hypoglycemia, and secondary, the coma is secondary to other reasons. Alcohol, acidosis, epilepsy, electrolyte, endocrine disorders, insulin, overdose of the drugs, uremia, so pathology of the kidney, trauma, low temperature, infection, psychoorganic problems, stroke, or tumors in the brain are also coma causes. This is the mnemonic way of remembering what can cause coma. Almost every pathology can cause coma, in fact. And vegetative state, if 2 weeks after 2 weeks coma, the patient should either get better or heal himself, or can go to the vegetative condition. Vegetative condition is a situation when there are preserved autonomic and motor reflexes. The patient has normal sleeping and wake cycles, but there is no contact with the patient. The patient has open eyes when is waken up, when sleeping has closed eyes. So the person looks like being waken up, but it's not waken up normal in a normal understanding of that way. The patient is unaware of the environment, unaware of her or himself. Terrible condition for the family. For the patient, it's not a terrible because the patient doesn't know what's going on, but for the family, for the next of kin, it's a terrible condition. The vegetative condition can change to minimally conscious state. Minimally conscious state means that patient looks very similar to the vegetative condition, but there's some evidence of awareness of environment. The patient may react to some commands, may observe what's going on. Generally, it's an information that if somebody is in minimal conscious state, it means that the person is improving. But nobody will tell you whether this patient will go on improving or this is just maximum. And this minimally conscious state will be till the end, for months, for years, forever. So we don't know much about the brain, unfortunately. We know what's going on. In many cases, we know what is going on. We can say that the patient is in coma, the patient is in stupor, that the patient is in minimal in vegetative condition, but we don't know what will happen. We cannot prevent, we don't know that. One patient from minimally conscious, from vegetative condition will improve totally, the other will stay like that. What we also observe in our patients are the qualitative problems, qualitative alteration, confusion, and but also the patient may see some strange things, may hear some, may be in delirium. The patient may not be able to follow some commands, some complicated commands. Confusion means that somebody is disturbed, has disturbed orientation in time, place, or person, talks to us, answers the question, are you hungry? What's your name? But where are you? Says on holidays. Or what year we have? 1980. So these are the the person may give you improper answers. Delirium, it's an acute confusional state which fluctuates during the day. So the patient who is in delirium may be very agitated, aroused, and then 1 to 3 hours later becomes very, very calm. Even not interested in everything, just somebody who is lying in a bed, maybe observing, maybe not, but somebody at whom you look and say, okay, this is the patient without the problem. The truth is that the patient has problems because delirium, hypoactive, hyperactive, or mixed delirium is a pathology that increases the mortality, and we should find out whether the patient is in delirium or not, and there is a special way to diagnose by asking questions to the patient, by asking patients to follow some commands. There is a special scheme for diagnosis of delirium, because we have problems with measuring objective ways of measuring consciousness. We have to look at several clinical signs, and very often the consciousness level is altered by the drugs that we give. There are some scoring systems and some observation that we use and some observation that we perform. We look whether the patient has continuously open eyes or the eyes are opening following stimulus, moderate or very vigorous stimulus, or patient is not opening eyes at all. So wake, alert, sleep, stupor, or coma, depending on how the patient reacts with opening the eyes. How to check awareness? We have to carefully observe the patient, examine the patient, sometimes few times a day. We very often ask nurses, what is the patient condition? Because the nurses are all the time at the patient's bedside. They may see that the patient during the day, that the patient's condition, awareness, consciousness changes during the day. The patient must be aroused in order to perform some cognitive processes required for awareness. So arousal is the minimum that is necessary to perform by the patient perform some processes. The very easy way of assessment of patient's consciousness is Glasgow Coma Scale. Very easy because it's written. There are exact 3 things we have to assess. And it's easy if the patient is not on sedation. If the patient is on sedation, Glasgow Coma Scale becomes totally not useful. Unfortunately, and Glasgow Coma Scale was a tool for the clinical assessment of post-traumatic unconsciousness. And Glasgow Coma Scale is incorporated in many scales, in many scores that we do in the ICU. So if we by incorrect assessment in Glasgow Coma Scale, we can very easily give incorrect results in other scores. What is Glasgow Coma Scale? We ask the patient to open the eyes. If it's continuously only to sound, to pain, or never, we give points. Then we ask the patient to do some motor response. If obeys command, depending on the reaction, the number of points is given. And the verbal response. If the patient is orientated, 5 points. If the patient doesn't respond at all, 1 point. So 15 is the maximum, 3 is minimum. Somebody with 3 points is a person who does not react, a person in a deep coma. But it cannot be used as a single assessment in the acute setting. However, a Glasgow Coma Scale in emergency department can be used, should be used everywhere, should be used as a safety precaution when we decide whether to intubate the patient or not. If the patient who is with good normal coma scale 15 deteriorates, the Glasgow Coma Scale decreases, you have to think what is going on. Is it something going in the brain? Is it something going in the whole body? For instance, sepsis, infection, this may present as a decrease of Glasgow Coma Scale. So declining Glasgow Coma Scale means patient's condition deteriorates, and we have to look for the reason. If the patient has Glasgow Coma Scale, trauma patient, and also other patients, 8 and less, and there is a clinic, it means that the patient's possibility of keeping the patent airway is decreased. So if there is a clinical concern that this patient is unable to protect their airway, we should intubate the patients based only on the Glasgow Coma Scale, 8 and lower. So the patient doesn't have to have respiratory insufficiency yet at this moment, but the poor consciousness means that the patient is at risk of asphyxia. So we have to prevent the patient from respiratory arrest by intubation the trachea. However, the creators of Glasgow Coma Scale wrote that they have never recommended using this Glasgow Coma Scale alone, either as a means of monitoring coma or to assess the severity of brain damage or to predict outcome. So we use Glasgow Coma Scale, but it cannot be the only tool for a patient's consciousness assessment. There might be some modification of Let's Go Coma scale in different countries. It's possible. There's if you modify your version, you have it in the country and it's on the national level. This modified version can be used. There's a pediatric Let's Go Coma scale. It differs for the children younger and older than 1 year old. Of course, motor response, it's hard to say that the child who is 2 months old will follow the motor response or verbal response. So this is more complicated in children. In the ICU, there are pitfalls in critically ill patients. How to assess the possibility of opening the eyes by the patient if the patient has edema or face trauma or the ocular trauma or the facial injury or has pathology of the cranial seven nerve or is under the neuromuscular blockade. The patient may be unable to speak because of the sedation, because of the artificial airway, because of fractured mandible, and the words will not be easy to understand. But if somebody who is unable to speak will write me the answer, I give the points for the speak. So if somebody who has intubation tube or tracheostomy tube cannot speak because of this tube and is fully conscious, should receive maximum number of points, even if you cannot hear the sounds. But so we have to be really flexible when we assess patients in the ICU. The same, there might be other reason of no motor response, not exactly caused by intracranial pathology. Somebody who has spinal cord injury will not squeeze the hand. Should I give, and the patient may be fully conscious. So I have to ask the patient, then open your eyes, close your eyes. I cannot ask the patient who has spinal cord injury to squeeze the hand, because if the patient will not squeeze the hand, should I give the patient 1 point? No. So this is not the pathology of the brain. This is the pathology of the spinal cord. So I have to ask the patient to do something, show the tongue, close the eyes, open your eyes, and assess this motor reaction. We can also assess the patient's wakefulness, consciousness by using, generally in the medicine, by using special, very precise, I forgot, very precise and complicated imaging techniques, but they are not used common. And as I said, many patients in ICU are sedated. And if the patient, the more severely sick patient is, the more sedation is used, and somebody who is mechanically ventilated in almost 100% will be sedated. And we need to sedate the patients because some maybe not too deep, not all of them. We have to fight with pain, but for some patients we use sedation because everything that we do in the ICU is very uncomfortable for the patient and may cause a nightmare. So we want to prevent the patient from remembering what was going on during this period. And sedative drugs, they give some amnesia. So we use sedation. Sometimes the sedation may be very light. It depends on the patient condition, but most patients are sedated. There are some indications for moderate and deep sedation, like severe respiratory insufficiency with problems with synchronization, patient ventilator. When there is surgical reason for immobilization, sometimes the patient should not move because the because they when they move, the effect of surgery, the surgery disappears. As when there's severe brain injury with intracranial hypertension, when the patient is receives muscle paralyzing blood, drugs must be sedated. When there's somebody in epileptic state, so sometimes we use deep sedation and moderate. In most cases, we use light sedation, and light sedation. With light sedation, we use Ramsey sedation scale to assess how deeply the patient is sedated. But remember, when the patient is sedated, the real assessment of consciousness cannot be performed. We assess how deep is the sedation, whether the patient is vigilant or asleep. But it will not tell me exactly what is going on in the patient brain. It will tell me how effectively I use sedative drugs. If the patient is a light sedation, we are able to monitor the brain function. If something wrong happens, the patient deteriorates, and the patient is in a light sedation, I will see this. If the patient is a deep sedation, no response to light, no response to loud noise, and has some new intracranial pathology like stroke, I may not be able to see that. That's why we shouldn't, if not necessary, we should not use deep sedation, only in very selected cases, just to keep us the availability to assess the patient consciousness. There are other sedation scales. You will have it, I think, in another in the next year. I think when we have lectures about sedation. Just to mention that we can use different sedation scales to assess the patient consciousness, the patient's sedation, depth of sedation, another one. And CAM-ICU is a tool to assess the patient's delirium. I told you that delirium is a fluctuating condition when the patient may be aroused or almost asleep, very calm. And if we do not use this tool called CAM-ICU, we will not diagnose the delirium. This is the CAM-ICU tool in English. We have a Polish version. And there, I think that there are different versions in different countries, different languages, and it's not only the version must be the local version must be validated. It's not only possible to translate it into the Polish. There must be translation and validation of the tool. For instance, if I in English, by checking how the patient is reactive, I say squeeze my hand on the letter A, and slowly I say save a heart. In Polish, it will be a word abracadabra. Yes, many A are in this word, but this is another word. And it was, and abracadabra is not translation of save a heart. This is totally different word. So the person who was in charge, there were several people who were translating this into the Polish language, into the Polish situation. They were forced to find a word which will allow the similar reaction of Polish-speaking people to the original tool. So if you will go to your country and you will find English CAM-ICU tool and you will like to use it, don't translate it exactly into your country, into your language. So that's the only way we can assess delirium. The level of consciousness in a very unprecise way, we can not assess. We can somehow try to assess by checking at clinical parameters: blood pressure, heart rate, sweating. When we talk, the patient is uncooperative. The patient is, we think that the patient is unconscious. And when we talk to the patient and suddenly blood pressure increases, heart rate increases, it might be an information that the patient gets some impulses, hears something, is hearing, able to hear something. But whether the patient is able to what the patient is able to do with this knowledge, that with this hearing, with this information, we don't know. We may just have a very inaccurate assessment that some impulses are felt by the patient, but nothing about the higher level of transmission of the signals. And also drugs may discard it. If the patient is on beta blockers, he or she will not be able to increase the heart rate. We can use also something called bispectral index in anesthesia to assess the level of depth of consciousness. It uses signals from brain and from muscle of the forehead, and it gives us numbers. Level of consciousness of anesthesia and deep anesthesia, like light sedation and deep in anesthesia. In ICU, it's not validated, so we shouldn't use it. We don't use it in the ICU. It's called BIS monitoring. So generally speaking, there is no way of clear assessment of critically ill patient if the patient is on sedation. If the patient is not sedated, we have some tools, but sedated patients, unfortunately, not. And nobody has created any tool, any device that will say us that the patient is what is the level of patient consciousness. So we observe some clinical, we examine the patients, we check the reflexes, and the best way of assessment is when we talk to the patient and we ask the patient to perform something and the patient responds to our command. That's the only way we can say that the patient is here, gets the information, the brain is able to use this information, and the brain is able to react correctly. If the patient is not following our commands, we don't know what is the level of the pathology. Hearing, detection of the impulse, or changing the impulse into the movement. This is very, very hard to assess.